I think it's an area of very active research. What we did observe, which I think is very important to share, is that when we looked at mutational burden at relapse after exposure to high-dose Melphalan versus not in the tumor, we saw a correlative with what we were seeing with MDS-AML. In other words, there was a significantly higher level of whole genome sequenced mutational burden for those patients in whom they had been exposed to high-dose Melphalan. Now, intriguingly, this is preliminary analysis partnered with our French colleagues in the IFM. When we looked at outcomes in small numbers of patients, but nonetheless looked at outcomes, it was by no means clear that this actually resulted in a particularly bad outcome. So the suggestion was, well, if that's the case, what's going on? Is there some immunogenicity generated by this mutational burden that's helpful? However, I think it's important just to bear this in mind. If you're starting with 7,000 mutations in your disease and you amplify it fourfold, there's a fourfold difference between relapsing after RVD versus RVD plus transplant. So you end up with 14,000 mutations on average, or 12 to 14 if you've had Melphalan versus 8.5 if you haven't. At some point there has to be differences in what that means. And of course, when this occurs, Esther, it occurs at relapse. So already the immune surveillance that the transplant has provided with maintenance has failed because the disease has come back. So the question then becomes, what then happens down the line? And I think we're studying that very actively. Preliminary data suggests it's not a disaster. Some studies show that. Other studies have been actually not quite so favorable and have said there's this issue of loss of disease control over time that's magnified. And why that's so important is that may go in part to explain why we see this tremendous PFS benefit, which is wonderful to see, but we don't see an OS difference. And that might be part of the explanation, but we'll see.